Expectations and knowledge amongst those that we serve have changed beyond recognition. Allied to this, the loss of deference that we have for many professionals, and replace that with earned respect, I think we're starting to see the world that we have today. The world that we send newly qualified clinicians to is changing faster than ever before. When my grandmother had her hip replacement in 1973, she clearly remembered the time before the NHS, when she had to call the doctor out when she was giving birth to my father and nearly died, but her biggest concern was how the doctor's bill would be paid. Now, she had a hip replacement in the 1970s, and she was eternally grateful. She didn't mind she had to wait 2 years for that hip replacement. When my dad was ill about 15, 20 years ago, he thought it was entirely reasonable that the NHS should make him wait 3 months to see a consultant. Look at the pressure the service is under. Look at the volume of people needing to access very busy doctors' time. My kids, they want services real time, preferably digital, and they don't understand why the NHS can't deliver that. Primary care is going to change beyond recognition. At some stage, will much of routine primary care be done via iPad from your kitchen table? Will we redefine the iPad as primary care, where you can be video conferencing with a doctor, perhaps on another continent, perhaps using a booth that at the same time you're having that consultation with a health professional, it's testing your blood, perhaps even dispensing medicine? Some people would say that's abhorrent. Some people would say that's the future. If it's the future, are we doing what we need to prepare for it? We are already preparing GPs for a world of distance and remote consulting. But are we going as far as we could in preparing them for an even faster changing future? Parity of esteem. That's not something that's going to happen just because we stand up and say it. If we mean it, we need to work at it. And that means starting early. Mental health nurses need to understand how to deal with the physical aspects of health and the consequences of mental health on physical health. But even more, adults and children's nurses need to be able to treat and care for those with mental illness. The same actually goes for all our clinicians, because it's only by mental health being seen and treated alongside physical health that we will erode that historic divide. Does this mean changing the nursing degree? Perhaps 2 years of nurse training in which everybody does children, adults, mental health, learning difficulties, before choosing a specialism in year 3. Perhaps a specialism could be community nursing. Does it mean increasing aspects of mental health training for other clinicians? Does it mean we need to do something to update all our workforce of the NHS on mental health matters generally? It might mean all of these things, but unless we do something, unless we interact with our workforce, parity of esteem is a nicely worded aspiration that will happen over decades. We need it to happen now. A simple question. Everyone I speak to tells me that the NHS needs to deliver more care in the community, joining up with social care and providing as much care as possible in people's homes, perhaps even bringing back a modern home help. They tell me that integration with social care is the way to make services better, giving the NHS a bottom right-hand corner incentive, a lever to make social care work. We need staff who are comfortable working across health and care boundaries, professionally, accountability, and dare I say, perhaps even planned and recruited in some cases as a single workforce. How far away from this are we? Certainly for the last 20 years, we've been talking about delivering healthcare in the community within reach into hospital when necessary. So why are we still training most people in hospitals with a bit of outreach into community every now and then? I tell you why. Service need. The training equivalent of double running. Hospitals need junior doctors, student nurses, allied health professionals in training for their current services, however much we say they're supernumerary. So moving training into the community makes the delivery of patient care hard. It makes it more difficult for staff, for patients, and for hospitals. That is the rate-limiting step. The current workforce has seen dementia and diabetes becoming the defining conditions of our age. But even now, we are still in the foothills of ensuring all staff know how to support people with these conditions. Through programs like Making Every Contact Count and the dementia awareness training I mentioned earlier. But we can't wait and respond. We need to be proactive. What's the dementia of the future? Or is it something completely different? What if our next biggest challenge is a communicable disease? The current workforce of the NHS has basically lived without a big challenge from communicable diseases threatening to kill millions. Even HIV and AIDS was 25 years ago. But what about bird flu in Asia? Always on the verge of mutating to a human-to-human contagion. Hundreds of birds in Norfolk were diagnosed with bird flu about a fortnight ago. More recently, the outbreak of Ebola, a disease that swum into the darkest recesses of our generation's fears for years, but now an outbreak and a vaccine. Again, necessity driving innovation at speed. So, do we need to think now about how we train our staff in dealing with pandemics or communicable disease again, building on what we learned from flu in 2009?